Thank you for joining us today. My name is Lauren Gleason, and I am a geriatrician at the University of Chicago Medicine. And today I'm joined by Dr. Kimberly Beiting, who is also a geriatrician at Vanderbilt University Medical Center. And we are going to be discussing vaccine hesitancy in the setting of COVID-19. Next slide. Our work here today is supported by the Health Resources and Services Administration, HRSA, under the Geriatric Workforce Enhancement Program. Next slide, please. When we think about vaccine hesitancy, the opposition to vaccines has existed since the introduction of the smallpox vaccine in the early 1800s. This satirical cartoon poked fun at the actual fears of the vaccine, which was made using the cowpox virus. And they thought that at that time, it could lead to strange mutations. And this, once again, showed a lack of confidence. Opposition intensified during that time as vaccine requirements became more common. Though these vaccine requirements were able to eliminate smallpox entirely. So once again, as we can see here, vaccine hesitancy is as old as vaccines themselves. Next slide. And vaccine hesitancy isn't just limited to COVID-19. Vaccines have helped significantly reduce infections like measles and polio, but we have not yet completely eliminated them, in part due to vaccine hesitancy at home and around the world. So why does vaccine hesitancy remain such a common problem in the history of human health? It comes down to three main themes. Number one, complacency. We perceive low risks of diseases that we often don't see, such as measles. Number two, lack of access. It's hard to get the polio vaccine to remote parts of the world. And number three, lack of confidence. Mistrust of the public health system has led to some actively fighting against safe and effective vaccines. Next slide, please. However, when we think about vaccine hesitancy is not set in stone. And vaccine hesitancy is not a fixed belief, even though it feels this way. This report is from the Kaiser Family Foundation, and it looked at vaccine hesitancy related to the COVID-19 vaccine over time. And as you can see here, between December 2020 and January 2022, a lot of people did change their minds about the vaccines. Many people who first had a wait and see approach, their attitude shrunk over time, as you can see with the light blue, and more of them did get vaccinated. Next slide, please. And vaccine hesitancy drivers are on multiple levels. Today, we are going to discuss the individual drivers via access, such as being homebound, complacency, fear of needles, fear of side effects, along with the macro level drivers, such as misinformation and myths. It's often seen on social media and Google. Access, we'll see information and underserved areas, and institutional mistrust, which is often seen in marginalized communities. Next slide. There are variable stages of vaccine readiness when we think about addressing vaccine hesitancy. And it's really important to determine the causes of why someone might be hesitant to obtain a vaccine. And there's wide variation of these causes and vaccine uptake, sometimes even within counties. Today, we are going to be discussing our perspectives from an urban and a rural point of view. In urban settings, we have traditionally found that predominantly underserved socioeconomic and racial demographics drive some of this vaccine hesitancy. In contrast to rural areas where poor access to healthcare and limited resources might be one of the main drivers to vaccine hesitancy. However, the first step to combating misinformation is really using a trusted source. And very often, healthcare providers are the most trusted sources of healthcare advice. Next slide. And here, case in point, is a case study from the city of Chicago. So this was taken from the dashboard of the city of Chicago. And to date here, 71.3% of Chicagoans have completed their primary vaccine series. This does not include booster doses. But as you can see here, the distribution of vaccines is not equal among demographics such as age, race, and ethnicity. And you will notice that there is a large variety of reasons and rates among these demographics, particularly with Black and Latinx less likely to receive these vaccinations. Next slide, please. And another example of this, just showing this information in a slightly different way, you can see the trend in vaccine uptake and the slow uptake in Chicago among the Black residents, as you can see here denoted in the purple color on this graph. And despite wide vaccine access, only about half of Black residents have received 2 vaccines. And additionally, when we look at a map of Chicago, we notice that the south and west side have lagged in vaccine uptake compared to the rest of the city. And these are neighborhoods and homes of many of Chicago's communities of color. So once again, next slide, please. As we look at this case study of the city of Chicago, why are there gaps? And why do we see racial and ethnic gaps in vaccination healthcare access more broadly? The first problem we can describe here is really a lack of access to medical care and vaccines more broadly. Communities in the south and west side often have fewer primary care providers per resident. And most Americans, as I mentioned in the slide before, really rate their PCP or their primary care provider as their most trusted source of information. While the city has been working hard to put these vaccinations in clinics in these hard-hit neighborhoods, such as especially using sources such as schools and churches, it has been an uphill battle. And while COVID-19 vaccinations were free at the time and still remain free, underinsurance often keeps people away from the medical system unless absolutely necessary. Then we also look at the lack of confidence, especially this mistrust of institutions such as city, the hospital, public health departments. And this mistrust is built upon decades of systemic opposition from those very institutions that are tasked with vaccine messaging and distribution. And this leaves the door open for really a lot of misinformation. And now I'll pass it over to Dr. Beiting.
Thank you, Dr. Gleason. So we just went through a case study of the city of Chicago, which is a representation of a lot of our urban centers in this country. I wanted to transition to a case study of rural Tennessee. In Tennessee, the highest percentage of vaccination completion rates is in urban cities, which is similar to the rest of the country. Rural areas of the state show less than 25 to 50% vaccine completion. So rural areas of this country are important areas to understand and address vaccine hesitancy. Survey results of adults in rural Tennessee reveal that more than half, 51%, indicated that at least they had some hesitancy towards vaccination against COVID-19, with 32.1% citing lack of evidence of vaccine effectiveness as the leading reason. COVID-19 vaccine hesitancy was more likely among those with more moderate or conservative political leanings, Black Americans, and residents of non-metropolitan areas. Other factors found in multiple studies that might contribute to COVID-19 vaccine hesitancy in rural Tennessee communities included conspiracy theories, misinformation or disinformation, fear, the fact that vaccines are approved under the emergency use authorization of the FDA and thus viewed as not full approval, lack of community health literacy, and distrust in the medical establishment. So let's talk about misinformation. Unfortunately, misinformation is everywhere. In this national survey from October of 2021, people were asked if they believed in or were uncertain about any of the false claims to the left. Many had a firm belief or doubts about multiple myths. Some of them, such as the belief that pregnant women should not get vaccinated, can have extremely serious consequences. Pregnant women should absolutely get vaccinated. 78% of respondents had heard at least one of these myths and were uncertain about the accuracy. These questions touched on whether the government was exaggerating the number of COVID-19 deaths, deaths being hidden by the government due to the COVID-19 vaccine, relations to infertility, whether you can get COVID-19 from the vaccine. And we're going to cover some of these myths and misinformation in the slides ahead. So what do you do when it becomes your job to challenge misinformation? This seems to be a new role that a lot of healthcare providers are playing these days. Communication experts recommend a strategy that sandwiches false information between factual information. Start with a statement of the fact. Identify the belief that is misinformed or misleading. Explain what makes the information untrue, whether it is just mistaken or intentionally misleading, and then finish with the correct information. So, for example, COVID-19 vaccines are safe and effective in pregnancy. This is a fact. The belief that pregnant women should not get vaccinated is not true. That's the warning. This misinformation may have come from the very early days of vaccination when researchers had not yet finished studying the vaccine in pregnancy. Back then, pregnant women were advised to wait for more guidance. This is the source of the fallacy. And then finally, ending with a fact. The fact is that vaccination is the single most important way to protect pregnant people and their children from COVID-19 and is completely safe. Here is another example using the myth that COVID-19 vaccines can cause COVID-19. Fact, the COVID-19 vaccine will not make you sick with COVID-19. Warning, misinformation alert, pointing out the fallacy. Some people are saying that COVID-19 vaccines will give you COVID-19. This is not true. While you may feel sick after getting the COVID-19 vaccine, that is a sign your body is building protection against the virus that causes COVID-19. Fact, the COVID-19 vaccine cannot make you sick with COVID-19. COVID-19 vaccines teach your immune system to recognize and fight the virus that causes COVID-19. Sometimes this process can cause symptoms such as fevers and chills. These symptoms are normal and a sign that the body is building protection against the virus that causes COVID-19. There are misinformation resources on the web that you can look at for more information. The CDC has a page, as well as the Cybersecurity and Infrastructure Security Agency, which has published a toolkit of resources to help address misinformation, particularly around the COVID-19 virus. You can scan this QR code to go directly to this toolkit and explore more for yourself. So let's talk about another way to address vaccine hesitancy. Motivational interviewing focuses on getting the individual to voice out the pros and cons with more focus on the pros when making a decision. Getting people to actually talk about their motivations changes how they process their choices and can help motivate change. We can use motivational interviewing to help explore and address vaccine hesitancy. When you are doing motivational interviewing, you should embrace an attitude of empathy and collaboration. It should never be an attack. Ask permission to discuss vaccines. You can ask questions related to motivational interviewing as follows. An example would be, what do you see as the positives of vaccines? What would help boost your confidence in vaccines? Respond to your questions. Motivational interviewing may take multiple discussions and clinical encounters, and that is okay. It is a process of building trust and collaboration with the person you're caring for. So these are some common questions that everybody asks, and we can address these questions to combat misinformation and vaccine hesitancy. The important thing is to remember that it's common for disease management recommendations to change over time. This is very standard in the history of medicine. Most immunization recommendations that are in place right now, things like the chickenpox vaccine, the shingles vaccine, have changed over time at least once. So the first question that we ask, are COVID-19 vaccinations safe? For a lot of people, asking whether these vaccines are safe equates to asking, were they rushed? So here's a timeline that shows actually the development of mRNA vaccines over the years. They have been in study for decades. Clinical trials of mRNA-derived therapeutics started around 2001 with the discovery of mRNA and the investigation of mRNA dating back as far as 1961. The knowledge from the years of study of mRNA was utilized to develop the COVID-19 vaccines when the pandemic occurred in 2020. The take-home message here is that the science behind these vaccines was not developed overnight. Scientists have worked with these types of vaccines for over 60 years. Here are some more myths regarding mRNA-derived COVID-19 vaccines. We've addressed a few in the prior slides. For example, the COVID-19 mRNA vaccine can give you COVID-19. This is a false statement. There are no live or full COVID-19 viruses in the mRNA COVID-19 vaccine. Therefore, the vaccine cannot give you COVID. Another myth would be the COVID-19 mRNA vaccine causes infertility. This is false. There is currently no evidence that any vaccines, including COVID-19 vaccines, cause fertility problems, which are problems trying to get pregnant in women or men. Furthermore, COVID-19 infection during pregnancy has been actually shown to increase the risk of pregnancy complications, including preterm and stillborn birth. COVID-19 vaccines that prevent against a COVID-19 infection can lower this risk. The COVID-19 mRNA vaccine will change your DNA. This is another false statement. The mRNA in the COVID-19 vaccine cannot change your DNA. The reasons for vaccination have remained the same since the vaccine was first available. Why should I get vaccinated? It's to protect myself, my family, and my patients or residents. It will help stop the spread of COVID-19 in the community. And COVID-19 vaccines will decrease the risk of getting COVID. They will decrease the risk of severe illness. They will decrease your risk of missing work, and they will decrease your risk of long COVID. These are all really important reasons to get vaccinated. I'm going to switch the slides back to Dr. Gleason.
So one thing I often hear a lot is no one is dying from COVID-19 anymore, so I don't need to get a COVID-19 vaccination. And I can tell you that no one is dying because of vaccination. So those individuals who are vaccinated, once again, are much likely to get the risks and side effects from COVID-19, as Dr. Beiting mentioned in the slide before. Next slide. So now, when we think about COVID-19 vaccines, which vaccines are available in the United States? And there is a choice. We have Pfizer, Moderna, the Novavax, and the Johnson & Johnson vaccine, or the Janssen vaccine. And these are free or covered by insurance, and you can get them at your pharmacies, the health department, or your local healthcare clinic. Next slide, please. So then talking about here, which vaccine should I get? And these vaccine recommendations are different depending upon your age and the vaccine you first received and the time since the last dose. And as Dr. Beiting mentioned before, the vaccine recommendations do change over time as our research and new developments arise. But in general, it is recommended that the 2 doses of a Pfizer or Moderna are recommended for younger children. And then as you get older, there are more options that are available for you among the vaccines here, as shown on the table. Next slide, please. So how effective are the COVID-19 vaccines? So right now, this slide, as the slide shows, that they're very effective after the second booster dose against critical illness, hospitalization, and death for the mRNA vaccines. The Janssen vaccine is 31% protective against hospitalization after 1 dose, 67% after 2 doses, and then more effective if you get 1 Janssen dose and 1 mRNA dose. However, this data is always changing, and keeping up with this is important. But once again, the message still is that COVID-19 vaccines are effective in reducing critical illness, death, and hospitalization. Next slide, please. And what about boosters? There are multiple booster options that are available right now. There's the Moderna bivalent, the Pfizer bivalent, and the Novavax monovalent. And as I mentioned, it is difficult to keep up with these changing guidelines. And it's normal for vaccine schedules to be updated and address new viral variants. So you can use this QR code that's shown here from the CDC, and it has the booster calculator and can give up-to-date information on which booster is best for you, depending on your age, situation, and locality. Next slide, please. So this is the best way with this QR code on how to stay up to date with all the changing vaccination guidelines. So just a tip, bookmark this site in your browser and scan this information for current up-to-date COVID-19 vaccination. Next slide, please. So once you do get vaccinated, what should you expect when I get the vaccine? So you might have some temporary fatigue, headache, muscle pain, or pain at the injection site after the vaccination. These reactions typically last for 1 to 2 days and often are more pronounced after the second and booster doses. But the side effects mean your body is doing its job. It's a good thing. It means your body's making antibodies to fight the virus. And these side effects are normal, common, and expected. And one more question here that I sometimes get is, should I be worried about having a severe reaction to the vaccine? And I would tell you, no, it's very rare. Some people do get anaphylaxis to it. That's very, very rare. And most of the severe reactions occur within the first 15 minutes of getting the vaccine. So after you get the vaccine, stay around to get monitored by the healthcare providers that are giving it to you. For the Moderna, Pfizer, and Novavax, there is a rare risk of myocarditis or pericarditis, which is inflammation of the heart. This has been shown to be greatest in males ages 12 to 39-year-olds. And one way to decrease this risk may be to have a longer interval, reduced with a longer interval. So having more time between the first and the second dose. So instead of waiting the 4 weeks, you might want to wait the 6 weeks. The J&J or Janssen vaccine has been shown to have some blood clots with those with low platelets. And this occurs at a rate about 4 cases per million doses and has resulted in some deaths. And because of this risk, vaccination with COVID-19's others than the J&J or Janssen vaccine is preferred. So it's preferred to get the mRNA vaccines. But once again, it's balancing the risks and benefits. And very often and definitively here, I can say that the benefits outweigh the risks for these vaccinations. And now I'm going to pass it back to Dr. Beiting.
Thank you, Dr. Gleason. So another question that often comes up, sort of in line with previous questions regarding reactions, is I'm allergic to eggs. Can I still get the COVID-19 vaccine? Yes, a full list of ingredients is available on the CDC website, but in short, the vaccines do not have eggs, preservatives, latex, tissues from aborted human fetal cells or animal cells, or any metals in them. Those are some common concerns that patients may have, and so you can tell them definitively the vaccines do not contain these ingredients. Another question that comes up, should I still wear a mask after I get the vaccine? The CDC guidelines currently are based on community level. So if your community is currently having a low level of COVID-19 infection, wearing a mask is personal preference. If the community level spread of COVID-19 is medium, the recommendations are to mask if high risk or immunocompromised. And if the COVID-19 infection spread is high, the current CDC guidelines are to mask indoors. State guidelines may be variable, and so you can read the state guidelines on your state's Department of Health COVID-19 resource page for more information. Ultimately, if you are worried about getting a COVID-19 infection, wearing a mask is never a bad idea. Another question that comes up, what if I already had COVID? Should I get the vaccine? It is safe to get the COVID-19 vaccine, even if you've already had COVID-19. And even if you have had COVID-19, it is important to get vaccinated. It could give you longer and better protection against the disease than the immunity from the infection itself. Even if you've had positive antibodies, you should get the COVID-19 vaccine for further protection. This does lead into this question. So some patients may say, my sister said it is better to get natural immunity than getting the shot. I would remind them COVID-19 severity is unpredictable. COVID-19 infections lead to the potential for long-standing health problems, even with mild illness. There are studies that show that severity of your initial COVID-19 infection does not predict whether you will end up with long-standing long COVID symptoms or not. And in addition, if you have a COVID-19 infection, you might get others sick. And even if you have a mild course, other people may not. So it's important to get vaccinated to protect those around you as well. So we touched a little bit on boosters before, but I wanted to go into it in depth a little bit more now. So boosters are not a new concept with the COVID-19 vaccine. They have been around for decades because we know that the need for repeated vaccination to stimulate immunity has been known for decades. This is seen all over the vaccine schedule for children. As we can see, boosters are recommended for children as young as 18 months for various vaccines that we give them throughout their childhood. Boosters are also recommended for a few adults. So as we get older, your doctor may recommend getting the pneumonia booster, and that's very common. Why boosters? So boosters are important because over time, our immune system naturally relaxes its defenses, and this can lead to a loss of protection against an infection or a loss of our antibodies. Repeated exposures to help maintain antibody levels is why the boosters are so important. So the booster itself is the repeated exposure to help maintain antibody levels. We can see this in the chart to the right with multiple rounds of immunization, including a booster. Our antibodies are more likely to stay above the threshold needed to protect you. This allows the immune system to respond more quickly to prevent infection. Sometimes reframing the terminology when you're discussing boosters may help address vaccine hesitancy. Framing a shot as a booster may make it seem extra or somehow unnecessary. And framing 2 shots as being fully vaccinated may no longer be the case as COVID-19 variants change. Boosters are not the cherry on top of the sundae. They are the third scoop in the sundae. So try alternate phrasing like, to complete your series, this is the next vaccine you need. For optimal protection, this is the next vaccine you need. I did want to address a special case of addressing misinformation in environments of care where there are patients with cognitive impairment. An example of this might be in the nursing home. We often see hesitancy from individuals who may not fully grasp the risks and benefits of vaccination due to cognitive impairment. These individuals may be actually at the highest risk for infection, so it's really important to take the time to provide clear and accurate information that they can understand. Handouts, posters, diagrams, and videos are all helpful, but direct conversation is usually the most effective tool in our arsenal at the individual level. So when you are having a conversation with patients with cognitive impairment, you should keep your explanations simple. Show that you're listening. Use pictures or demonstrations that may be easier to understand. Include your patient's caregivers in the conversation as well. and repeat key points. The CDC has more information on discussing COVID-19 vaccinations in with those living with disability. So finally, where can I find accurate information? It's always important to know where your sources are. The most easily accessible and up-to-date resource is the CDC website at cdc.gov. And then, of course, your medical provider, your primary care doctor, or the person you see regularly will always be happy to discuss this with you. Accurate information is not usually found on social media, and social media can hold the risk of misinformations and opinions based on misinformation, as we have discussed prior. So this ends our discussion on vaccine hesitancy today. Thank you so much for listening, and we hope you learned a lot.